Welcome to today's ILHEMA webinar titled 2009 CPT Changes. Today's presenter is Dr. Lisa Campbell, PhD, MPM, MHA, RHIA, CDIP, CCS, CCSP, CPC, COC, and CPCI. Dr. Campbell is a multifaceted healthcare professional with 25 years experience, having a passion for working with physician practices. Dr. Campbell enjoys helping providers improve their operational effectiveness with a focus on documentation improvement and integrity. As a reminder, today the lines are muted so that we can get a quality recording of the webinar. And approximately 1 week after today's webinar, all registered participants will receive an email with an evaluation link. And after you complete that evaluation, you will receive your CE certificate. You will also have a link to the handouts and to today's recording in that email. Okay, Dr. Campbell, let's go ahead and get started. Dr. Campbell, can you hear me okay?
Oh. All right.
Hello there.
Okay, thank you. I was talking, but you couldn't hear me. All right, so good afternoon, everyone, and welcome. Before we begin, I would like to give a couple of disclaimers. Number one, given the amount of information that I have to cover today, there will not be a question and answer period. You can feel free to send me your questions via email, and I'll have my email address at the end, and then I can answer them at that time. The other disclaimers that I want to give you is that today's presentation is based on my own research of the 2019 CPT code set. This presentation was not designed to give any coding or legal advice. As you know, there are many variables that impact your code selection. Coding should be considered on a case-by-case basis. It should also be based on the actual documentation in your health record. Additionally, I am not one of your insurance payers. I do not work for a payer. And so I recommend that you contact them directly with any payer-specific questions that you may have. And also, as I'm sure many of you know, the CPT code set is a registered trademark of the American Medical Association. In terms of our objectives for this afternoon, there are approximately 335 changes for this year's code set. It is my goal to provide you with an overview of those changes, including the rationale behind those changes, and for you to be able to apply the concepts that you've learned today in your day-to-day practice. Keeping in mind my disclaimer that this information is not intended to be legal or coding advice. Also, we really want to look at how documentation plays an important role in the day-to-day coding process. And I went backwards instead of forward. All right. So, as I mentioned, there are a total of 335 changes for this year. Of those changes, we received a whopping 212 new codes. 73 codes were deleted. In some cases, they were deleted and converted. And then we have 50 revised codes. For those of you who are not familiar with the code revision process, on an annual basis, the AMA and the advisory committee gets together and they analyze claims data, they analyze comments from the users of the CPT code set, which would be all of us, And they look at where changes would be most appropriate for the upcoming year. It could be a situation where there's a new technology that's out there, and the inventor of that technology has gone through a process of getting a Category 3 code approved. And so what you're going to see today is the end result of their effort in our 2019 code set. And some of the changes are just editorial revisions where they've added a letter S to a word, for example, to indicate perhaps that it's one biopsy versus several biopsies in a particular code. As this particular chart indicates, the largest amount of changes took place with your pathology section, followed by Category 3, and then, of course, it wouldn't be a year of CPT changes if we did not have changes to the cardiovascular section. All right. Also, throughout the presentation, I will be utilizing the CPT code set symbols that identifies if a code is new or if it's revised or if the code is resequenced, and there was a lot of resequencing going on this year. In fact, I was looking, preparing for this presentation, and I was looking for a code, and I couldn't find it, and I thought it wasn't there, when in fact it was resequenced, and I needed to just put my resequence hat on to locate the code. All right, so let's begin, and I want to let you guys know up front, I have a little bit of a cold, so I may pause to drink of some of my hot tea, so I don't want you to think that I actually disappeared. So with our evaluation and management section, we had 6 additions and 5 revisions. Of note, I should mention that in this presentation, I also will not get deep into code guideline changes, and what I mean by that are any of the subsection notes that were revised. If I were to cover that, we'd be on here for 8 hours. So we're really going to be looking at those new and revised and, in some instances, deleted codes for 2019. So somewhere around, I want to say, I was looking back in my notes, it was either 2013 or 2014, we received some codes for the evaluation and management section to reflect a newer way of providing consultations. And that modality was either telephone or internet. And so this year, the 4 codes in that family, which are our assessment codes, had an editorial revision to change the terminology, or to add the terminology of electronic health record. These codes do vary based upon time, and you will notice that these codes are reported by a consultant, and that consultant is then providing a verbal and a written report to the patient's treating physician or the qualified healthcare professional. Now, that's not all for this area. We also received 2 new codes, 99451 and 99452. These are resequence codes as indicated by the pound sign. 99451 is used to report an interprofessional consultation service provided by a consultative physician, whereas 99452 is an interpersonal referral service provided by the treating physician or the requesting physician or a qualified healthcare professional. We have a new subsection with 2 new codes. This subsection is called Digitally Stored Data Services and Remote Physiologic Monitoring. There are a total of 2 codes, as I mentioned. 99453 is used to report remote monitoring of physiologic parameters. And those physiologic parameters are like your vital signs. This code is to be reported once for each episode of care, and you'll notice that 99453 is for the initial setup and patient education on the use of the equipment. 99454 is the device supply code for, or the device supply for daily recordings or program transmission, and notice it says each 30 days. Now, those two codes are resequence codes, and something that has happened to this particular section that I don't recall seeing before, even though Ann mentioned that I've been in this industry for 25 years. I'm only 25, so I don't ever recall a medicine section code being moved over to evaluation and management. However, this year in 2019, one of our medicine section codes, which was 99091, was resequenced from the medicine section to the evaluation and management section. And this is actually appropriate because the code is related to the collection and interpretation of physiologic data. And so it makes sense that this code was resequenced here. Next, we have another new section with one new code, and this section is for physiological monitoring treatment management services. And this code, which is 99457, requires live interactive communication with the patient or caregiver and 20 minutes or more of clinical staff time. And clinical staff, physician, or qualified healthcare professional in a calendar month. Now, when I looked at this code, I said, I really need to understand, how does this code compare to 99091? So, a couple of things. Number one, 99457 includes clinical staff time. 99457 is for 20 minutes or more during a calendar month, whereas 99091, and I'm going to go back a slide, notice this says 30 minutes of time each 30 days. So one is a calendar month, the other is 30 days. All right, and our chronic care management code were provided with a new code, and this particular code reports chronic care management provided by the physician or qualified healthcare professional for at least 30 minutes per calendar month. Reporting of this code does require certain elements. The provider has to be managing multiple conditions, multiple chronic conditions identified as 2 or more conditions, with these conditions expected to last at least 12 months or until the death of the patient. These conditions also have to place the patient at significant risk of death. Also, there has to be a comprehensive care plan established, implemented, revised, or monitored. Again, as I mentioned at the onset, we're not only going to look at the new codes, but also the importance that clinical documentation plays in the code assignment. All right, so that's it for evaluation and management, and now we're going to move over to the surgery section, starting with the Integumentary system, where we received 15 new codes, and one code was deleted and revised. So, remember our fine needle aspiration codes 10021 and 10022? Well, 10022 was deleted, and 10021, which is fine needle aspiration biopsy without imaging guidance, was revised because we now have 2 codes to reflect F&A without guidance, and they are divided based upon first lesion and each additional lesion. But that's not it. We also received some additional codes as well as some instructional notes for these codes that defines fine needle aspiration biopsy and a core needle biopsy. So our new codes are divided by the different types of guidance. So remember, 10021, existing code, no guidance, first lesion. New code, 10004, is each additional lesion, both with no guidance. The subsequent codes that follow are divided by the different types of guidance. This actually reminds me of the changes that were made to the breast biopsy codes a few years ago, where they were divided based upon the guidance. So 10005 through 006, that's ultrasound guidance. The next two are fluoroscopic guidance, followed by 2 codes for CT guidance and 1 code or 2 codes for MRI guidance. Again, the structure is first code, initial lesion, second code is for each additional lesion. We also had some revisions to the biopsy code. So you know those 2 biopsy codes that we have today. Those biopsy codes are for the express purpose of obtaining tissue for a diagnostic histopathologic tissue, and we only had 2 options. Well, 2019 brings the following changes. First, we have 2 new codes for a tangential biopsy. If you're like me, you're like, what's that? So a tangential biopsy, and just so you know, I'm a Google researcher. I research every word that I don't know. So a tangential biopsy is performed with a sharp blade to remove a sample of epidermal tissue, and it could also involve some of the underlying dermis. So we have 2 codes, 11102, 11103, first lesion, second lesion. You see the theme here with our codes in this particular family, followed by 2 new codes that describe a punch biopsy. And what's a punch biopsy? It's a procedure that involves a punch tool, henceforth the name punch, to remove a full thickness circle, if you will, sample of skin and subcutaneous tissue, and it includes the closure when performed. First code, initial lesion, second code, each additional lesion. Then we have 2 new codes that describe an incisional biopsy. An incisional biopsy is one that's performed with a sharp blade to remove full thickness sample of tissue via either a vertical incision or a wedge that's penetrating deep to the dermis all the way down into the subcutaneous space. Again, first code is going to describe the first lesion, and then the second code is going to describe the subsequent lesion. All right, on to the musculoskeletal system. 4 new codes, 2 deletions. Our first set of codes here are 3 new codes for allografts. And these codes are divided and include templating, cutting, placement, and internal fixation. 20932 is for osteoarticular. 20933, hemicortico partial. 20934 is for hemicortico, and it is a complete procedure. Of note, these are allograft, allo, not auto, so allograft procedures, and this is where bone is obtained from a donor that's used in the grafting procedure. All right, next up, we have a new code for an arthrogram in a knee joint. Now, I know you're thinking, wait a minute, we already have a code for arthrogram in the knee joint. You are correct. Remember I said that the AMA gets together with the advisory panel on a yearly basis, and they look at patterns and codes. So one of the things that they do is if they notice that two codes are used together more than 75% of the time, what we're seeing as a trend is that they are deleting one of those codes and creating one, what I like to call a combo code, that includes the procedure, in this case, which is the arthrogram, and then it also includes the imaging all in one code. All right, wouldn't be a year of CPT if we didn't have some changes to the cardiovascular system. All right, so we actually have currently in our 2018 manual codes 0387T and 0388T. And those codes describe a leadless pacemaker. For those who are not familiar with the leadless pacemaker, it's a small device, implantable device, that sends electrical pulses to the heart whenever it senses that the heartbeat is too low. With a leadless pacing device, those are placed directly in the heart without the need for a surgical pocket and those wires, electrodes, also known as leads. So here, our two Category 3 codes were converted and added to the pacemaker codes, the current existing codes, pacemaker, implantable defibrillator codes, and the terminology includes the insertion or replacement of a permanent leadless pacemaker. 33274 is our code for insertion or replacement. 33275 is the code for the removal of this leadless pacemaker. Notice these are resequenced codes. Next up, we have codes for subcutaneous cardiac rhythm monitoring. So a little bit of history on these. These are EP or electrophysiology devices that are used for long-term monitoring of the patient's heart electrical activity. And the goal, because it's an EP device, is to detect when the patient is having some type of arrhythmia. The goal behind this particular device or technology is to eliminate the need for those big, bulky Holter monitors where you have all of those leads and wires that are attached to the patient. And so for 2019, we have two new codes for these devices. The first code, 33285, is for the insertion, and 33286 is for the removal. Next up, we have a new subsection called implantable hemodynamic monitoring. A little bit of background on this type of device. Again, I told you I'm a researcher, and not that I am thinking that you guys don't know what these devices are. If we don't code in these specialties, we really don't. So those of you who do, pardon me. But this particular device is for patients with Class 3 heart failure who have been hospitalized the previous year for heart failure. And this device provides hemodynamic data that's used by the physician or qualified healthcare professional for heart failure treatment with a goal of reducing heart failure hospitalizations. So, given this device and what it's used for, patients who have this implant generally have a diagnoses of congestive heart failure, and these patients are monitored weekly for the duration of their life. And so this is code 33289, and notice it is a combo CPT code because it includes everything, the radiological S&I, as well as the pulmonary artery angiography, one of my favorite CPT words, when performed. All right, next up, we have a new code, not a new procedure, for cardiac valve. This particular procedure is for the aortic valve. Essentially, what this is a combination of two codes into one code. This procedure is known as a Ross-Cono procedure. And again, I'm going to tell you what it is because I like to Google. It's a procedure for treatment of complex, multi-level, left ventricular outflow obstruction. And this is typically a procedure that's performed early in life. The goal is to try to avoid repeated surgical re-interventions. So it combines two procedures into one Category 1 code. Next up, we have a new code for thoracic aortic aneurysm. As you know, this is a condition that occurs in the largest artery of our body, which is the aorta, which passes through the chest. And this particular code is for an aortic hemograph or hemiarch graft, which includes the isolation and control of the arch vessels. All right, we had some changes to our central venous access procedures. Now, if you code these procedures, you are familiar with them. They're divided based upon if the catheter is peripherally inserted or centrally inserted, whether or not there's a pump or a port. And these vascular access devices are used for those patients who need to have a lot of blood draws or fluids or blood or nutrition over a period of weeks, months, or even years. So for 2019, we have two new codes, 36572 and 36573, which are divided by age, of course, just like the other codes. But what's unique about these two codes, they are for PICC lines. They do not include a subcutaneous port or pump. However, they include imaging guidance. As a result of these two new codes being added, there were some changes to the existing codes. So 3656869 was revised to clarify that this is a PICC line insertion without imaging guidance. 36584, which is for the replacement, complete replacement of a PICC line, this particular code clarified to indicate that this procedure includes all of the image guidance, image documentation, all of the radiological S&I that's required to perform the replacement. All right, on to the Hemic and lymphatic system. We have one new code, which is 38531. This particular code is designed to report a biopsy or an excision of an open, notice the word open, inguinofemoral lymph node. Next up, our digestive system had a couple of additions and deletions. First up, you know our G-tube codes? G-tube codes for replacement were added for the 2019 code set. Our existing code, 43760, was actually deleted. The reason that these codes were added to the 2019 code set is there needed to be clarification of a simple G-tube replacement versus a complex replacement. So 43762 is the replacement. It includes removal with or without imaging, without imaging or any type of endoscopic guidance. But 43762 does not include revision of the gastrostomy tract, whereas 43763 does require revision of the gastrostomy tract. Next up, oh, am I going backwards? I had too much caffeine. All right. Next up, our urinary system, 3 additions, 1 deletion. So, under the area of other introduction, injection change removal procedures, we have 2 new codes, 50436 and 50437. 50436 is used to report the dilation of an existing tract percutaneously for an endourologic procedure. This particular procedure does include imaging guidance as well as post-procedural tube placement. Compared to 50437, this code is reported when new access into the renal collecting system is performed. Notice codes that are out of sequence. Next up, we have a new code for transurethral destruction of prostate tissue. A little background about this particular procedure and why it was established. So this procedure is being created for patients that have an enlarged prostate or BPH. Based on my research, I found that more than 3 million patients have this condition on an annual basis. Very common in men over the age of 60, can cause difficulty with urination, creates a feeling of urinary urgency. And so to try to treat this condition, doctors are turning to nature for this treatment. With this particular type of treatment, steam is used to treat the tissue to be vaporized or ablated, which essentially is going to cause the tissue to die in that area. And then over time, the body actually reabsorbs the tissue. Based on my research, I learned that this treatment can actually improve the patient's symptoms by 50%, and it can provide relief for like 3 years. And it can also preserve sexual and urinary functions. So this is our new code for this transurethral destruction of the prostate, and the technique is radiofrequency generated vapor thermotherapy. All right, next up we have our urinary system, 1 deletion and 2 revisions. So for the first 2 codes here under endovascular therapy, 61641 and 61642, we have an editorial revision. First thing to note, if you'll notice, this is a balloon dilation. The first code is for each additional vessel in the same area. The second code is for each additional vessel in a different area. And the change that was made this week or this year is the word family, like vascular family, was removed and replaced with the word territory. Also, I wanted to note, and this was something that I was very excited about, Appendix L in your CPT manual, and that's the one that has the vascular families, the one that I honestly, every time I looked at that appendix, I got very confused. Well, they did a major redo of that particular appendix to show the different vascular families, and so you can refer to Appendix L for a full description regarding the vascular branches or vascular territories. I think some of us are still going to call them families, but they're territories now. All right, on to the radiology section where we had 10 additions, 4 revisions, and 6 deletions. All right, so first up, for code 74485, under the urinary tract, there were actually 2 notable changes. The first change, and notice this is for dilation of the ureter or urethra. The first change is in 2018, this particular code includes the word nephrostomy. That word was removed. That's one change. The second change, and you'll notice behind the word ureter, there is the letter S in parentheses. In our 2018 manual, there is no parentheses around the S. And so this year, there is a S because there are 2 of them. All right. And so this change allows the procedure to be done on 1 ureter or 2 ureters. Okay, next up, we have a new code 76931, which is for magnetic resonance elastography, another procedure that I was not familiar with. This procedure, known as MRE, is a new way to image the body. It works by combining MRI imaging with sound waves to create a visual map, which is known as an elastogram, showing the stiffness of body tissues. This test can measure the stiffness of the liver for patients with known or suspected liver diseases. So that's code 76931. Then we have 2 new codes, 76978 and 76979, for non-cardiac ultrasound targeted dynamic microbubble sonographic characterization. The first code, 76978, includes the contrast evaluation, and then 76979 is for each additional lesion. And someone has pointed out in the chat box, I had a little typo on one of my codes, and so for the elastography, it should be 76391 and not 76931. Thank you so much. All right. Uh-oh, wait a minute. I'm going too fast. Too much caffeine again. All right. We have 3 new codes for ultrasound elastography. And those codes are 76981 through 76983. These 3 new codes distinguish, number 1, they're divided based upon the organ, and then they also are divided based upon the first target lesion or each additional target lesion. This is a relatively new diagnostic imaging technology. All right, next up, we had 2 revisions to our MR imaging codes. The first one, 77021, had an editorial revision to clarify that this is an image guidance code. And 77022, same thing. This is an image guidance code. All right, so the breast MRI codes received a really huge overhaul. So currently, for MRI procedures on the breast, we have codes 77058, 77059, and then category 3 code 0159T. Instead, we have the following new codes. First up, we have code 77046 and 77047. That is our MRI of the breast without contrast material. And then we have 77048, 77049, which are codes that include without and with contrast material. And then these two codes also include the computer-aided detection. Also, you will notice that the first code in each family is a unilateral code, and the second code in each family is a bilateral code. All right, next up, code 77387, which is guidance for localization of target volume. This particular code had a very minor editorial revision. And the editorial revision was that the word delivery was listed twice in the code. And so because the word delivery being used twice was redundant, one of the words was actually removed. That's all. Next up, pathology and laboratory. Over the last, I want to say, maybe, seems like about 6 years, the pathology and laboratory section has been getting changes in the code family of molecular pathology. So this year is no different. There were 95 new codes added for the pathology and laboratory section, 5 deletions, and 15 revisions. Quite naturally, because of the limited time that we have available today, I will not be covering all 95 of the pathology codes. I will tell you, however, of the 95 new codes that have been added, 44 of them fall under the area of proprietary laboratory analysis, and then 45 of them are Tier 1 molecular pathology codes. So if this is an area that you work in, you'll definitely want to review these changes. So also, 27 of the gene testing codes were moved from a Tier 2 code to a Tier 1, and then we also received 6 new Tier 1 codes. We have a new code for a test called DHT, and again, I didn't know what DHT was, so I researched it, and it has many roles. It can produce hair. It is also linked to BPH, or enlarged prostate, or cancer. It is also a sex steroid, so what that means, it is produced in the gonads, and it is also an androgen hormone, andro meaning man. So we have a new code for this particular test in our chemistry section. We also have code 83722 for lipoprotein. Now, when I first saw this, I said, oh, we already have lipoprotein codes. What's new about this code? Well, our existing lipoprotein codes indicate terminology like high LDL or very low. This particular code was established for small, dense LDL cholesterol. I already mentioned about the revisions to the PLA. Again, if you work with these codes, you'll want to take a look at them. All right, on to the medicine section, 29 additions, 13 deletions, and 17 revisions. First up, we received a new pediatric influenza virus vaccine code 90689. I think for the last couple of years, we've received new vaccine codes. All right, we have two new codes for electrorhinography or retinography, however you pronounce it. This procedure, test, abbreviated as ERG, measures the electrical responses of various types of cells in the retina, including photoreceptors, inner retinal cells, as well as ganglion cells. The second code is differentiated from the first code in that it is a multifocal ERG procedure. This procedure is known to be useful in solving what physicians refer to as a puzzle of a patient that has poor vision but has a normal appearing retina. So everything isn't as it seems. Okay, so remember I presented a new code in the cardiovascular section for the wireless device. And so first up, this is an existing code category that received a new code for remote monitoring. So first things first, this area has a new title. The new title is now implantable, insertable, and wearable cardiac device evaluations. And so this first code here, out of sequence, 93264, is for a situation where the patient has already had the device inserted. Remember, this device is pulmonary artery pressure measurement code. And this is when the patient is having, as the code indicates, at least weekly provider-to-patient contact with review of these measurements during a 30-day period. Now, some other changes that you're going to see on the next couple of slides, and just to make sure that I can get through to the Category 3 codes, I'm going to tell you that some of the changes really includes adding the word leadless pacemaker system, because that's now a Category 1 code. Other changes you're going to see subcutaneous cardiac rhythm monitor in the place of implantable loop recorder. And so that is also the same with these codes. A lot of the device terminology has been revised. And same thing here, again, changes made to include subcutaneous cardiac rhythm monitoring in the place of the implantable loop recorder. Also, you're going to see in code 93297 that they've added the word physiologic cardiovascular data elements. Okay, next up are codes for pulmonary diagnostic testing and therapies. These two codes are for car seat bed testing for airway integrity. One change here. the term neonate has been replaced with the phrase for infants through 12 months of age. The first code is for 60 minutes. The second code is for each additional full 30 minutes. Okay, next up, we have a subsection called electrocorticography. This particular code was established to report recording of a patient that has a deep brain stimulator or neurostimulator device implanted already. So this is for the recording. So a little bit background on this procedure or this device. This is often referred to as a brain pacemaker, which is designed to send electrical impulses through the implanted electrodes that specifics different targets on the brain. Very commonly used in the treatment of movement disorders, such as with patients that have Parkinson's disease or tremors. This particular device, the reason that this code was needed, this allows the provider to collect intracranial readings after the patient has been discharged from the hospital. All right, we had some major changes for neurostimulators. So, a couple of things. We had some new codes added. We had some existing codes revised. We had 4 codes deleted. And then we also have something that I personally enjoy. I don't know if it's because I'm aging, but we also have several tables to clarify reporting of these particular services. So, for example, with code 95970, there was a note added to clarify that the intent of this procedure is for electronic analysis of the implanted neurostimulator pulse generator. Other changes that you're going to see with these particular codes, and I have a list of things to tell you, and if you're coding these procedures, you'll definitely want to review these notes. So I already mentioned the word electronic analysis. You're also going to see addition of the fact that the qualified healthcare professional may be involved with this procedure. Also, differentiating the anatomy that's used with these codes. So, is it cranial? Is it peripheral nerve? Is it a sacral nerve? And then we have 4 new codes to complement the existing codes. And the intent of these new codes is to differentiate first a simple versus complex simulation procedure. And notice these are for your cranial nerve neurostimulator procedures. And then the second 2 codes have a time component added. And the first code is for the first 15 minutes. And then the second code, which is an add-on code, is for each additional 15 minutes. Of note, there are all different types of exclusion notes, instructional notes that are either going to say, do code this procedure with this procedure, or do not code that procedure with this procedure to ensure correct coding. All right, we have 8 new codes to address deficient adaptive behaviors. And these are the adaptive behavioral services codes. Of note, there are some cool tables in our CPT manual for these services. For example, we have new code 97151, which is adaptive behavior assessment services by a physician or a qualified healthcare professional. But then we also have 97152, which is when there is a technician who is being directed by a physician or qualified healthcare professional. Now later, I'll go over Category 3 code, I believe it's 03362T, and over by code 97151, there's actually a table that compares the differences between these codes, which I appreciate having a table that I can glance at to tell me what the difference is in those codes. All right. The next set of codes are for adaptive behavior treatment services, and those are 97153 and 97158. These are all time-based codes. So what I've done in my brain to make sense of all these different codes and the descriptions, I've grouped them based upon the intent. So they're all behavior treatment codes. They're all time-based codes. But 97153 and 97155 is designed to be used with one patient. 97154 and 97158 is for a group of patients, with CPT defining a group as 2 to 8 patients. 97156 is for family guidance, with or without the patient present. And then 97157 is for multiple family guidance. All right, our developmental, behavioral, screening, and testing codes got some new codes. First up, we have developmental test administration, including all different types of assessments, includes interpretation and report. The first code is for the first hour of service, and the second code is for each additional 30 minutes. Our next new code, 96121, was added to complement an existing code, 96116, which is for a neurobehavioral status code. This code is a face-to-face service with the patient, as well as time interpreting the test. This code can be reported by the physician or qualified healthcare professional. The first code is divided by the first hour. The second code is for each additional hour. And notice the first code has a telemedicine symbol in front of it. All right, next up, we have two new codes for psychological testing evaluation services. Same setup as the previous codes that you saw. First code 96130 for the first hour. Add-on code 96131 is for each additional hour. Two new codes for neuropsychological testing evaluation services. And 96132 for the first hour. 96133 is for each additional hour. The one thing that I wanted to note about the last four codes, and let me just go back a slide so you can see this, 96130, 96131, and then 96132 and 33, all four of these codes include interactive feedback to the patient, family members, or caregivers when performed. All right, we have four new codes for testing, administration, and scoring. So we have, and these are, of course, time-based codes. So So we have 96136, 96137. This is used when the physician or qualified healthcare professional is performing the service, whereas 96138 and 96139 are used when the technician is performing the service. Something else that is unique to these four codes is that they include the verbiage 2 or more tests by any method. So, in case you were like me and was wondering, well, what happens when there's less than 2 or more tests? There is a new code, 96146, which is for psychological or neuropsych testing, and this is for a single test. All right, and the last part of our session. Again, given the limited time that we have available for today, at the end of this session, you will be provided within a week a copy of the recording as well as an evaluation form. Also, at that time or during the next week, if you do have questions about something that was covered, you can go ahead and shoot me an email about that because we will not have time today to take any questions. All right, so Category 3. Seems like every year, Category 3, we're getting new codes, new inventions. So we had a total of 38 additions, 29 deletions or conversions. And so when I say conversions, what I mean is, remember earlier how I talked about some codes were in Category 3 and then they were made a Category 1? That's what I mean by conversion. And then we had 3 existing codes that were revised. All right, so first up, we have 2 new codes for extracorporeal shock wave. Now, I know if you're like me, when you first saw that terminology, you instantly thought about lithotripsy. Well, lithotripsy has been around since the 80s for treatment of renal stones. And so more recently, extracorporeal shock wave therapy has been investigated as a non-invasive treatment of musculoskeletal conditions such as plantar fasciitis, and it is also being investigated as a treatment for integumentary wound healing. So our first code of 0512T is for the initial wound, and then add-on code 0513T is for each additional wound. All right. We have 2 new codes for the sinus tarsi and 1 revised code. So a tarsal sinus, also known as a sinus tarsi, is like a circle cavity. If you look at a diagram, it's a circle cavity that is located between the talus and the calcaneus on the lateral aspect of the foot. And so 2 new codes were created. 1 existing code was revised to better clarify or identify the insertion, which is 0335T, the removal, 0510T, or the removal and reinsertion, 0511T. So again, created, revised to better clarify procedures on the sinus tarsi. All right. So a little while ago, I talked about the different changes that were made to the adaptive behavior services and the different guidelines that correspond to adaptive behavior treatment codes in Category 1. Well, there needed to be some revisions to this particular code as well. So, number one, in 2018, there was a word exposure added or in this code description, and so that word was removed. Also, this code now includes a time component of 15 minutes of technician's time face-to-face. Additionally, there are 4 components that are required for this service. Those components are: the test has to be administered by a physician or a qualified healthcare professional who is on site. So that professional has to be present. The next thing is there has to be assistance of 2 or more technicians. So that means 2 or more technicians have to be present, has to be documented in the record. The patient also has to exhibit destructive behavior, and then this service has to be completed in an environment that's customized to the patient's behavior. All right, then 0373T was revised to again remove the word exposure. Just like the last code, the time component was added, and then the same 4 components that were required for the previous code are also required for this code as well. Okay, new code 0523T. This is a code that was established to report non-invasive intraprocedural coronary fractional flow reserve, also known as FFR. Again, I told you I'm a researcher, so I researched this procedure. And this is said to be a procedure that's groundbreaking, and it's designed to help physicians objectively, not my words, but based upon my research, objectively and cost-effectively determine if the percutaneous coronary intervention, PCI, is indicated in every coronary angiography procedure. So this is an add-on code that has to be reported in addition to the code for the primary procedure. All right, next up we have code 0505T. This procedure has a lot of things going on. Number one, it is an endovenous FemPop arterial revascularization procedure. It includes the transcatheter placement of the stent, closure by any method, vascular access. It also includes ultrasound guidance for vascular access when performed, all of the caths, the road mapping, the imaging guidance, the radiological, S&I, of course, my favorite word with CPT, when performed, as well as crossing of the occlusive lesion. The other thing about this code is that there are lots of instructional notes. Instructional notes like, do not report 0505T in conjunction with other codes, primarily codes from Category 1. And then quite naturally, because this code does include ultrasound guidance, this particular code has a note that indicates not to report the ultrasound guidance code with this procedure. All right, we have a new code, 0506T, which is for macular pigment optical density measurement. Again, I was like, what is this? So, based on my research, I learned that our eyes have internal sunglasses, which are known as macular pigment. And this yellow pigment is found in the center of the retina, known as the macula, and it plays a critical role in protecting the macula from harmful blue lights, and is helpful in maintaining the function of the macula. Something else I learned, and I apologize for those of you who know about all of these different procedures, but one of the things that's helpful for me with CPT Changes is really understanding the intent of these procedures. So the other thing I learned is that the thickness or the density of the macular pigment varies from person to person, and the density can actually change over time. And of course, some of those factors are things like age, etc. So this particular code was created to capture the measurement by this particular technology. Now, this is a code that is unilateral or bilateral, and it includes interpretation and report. Next up, we have 0507T, which is near infrared dual imaging. And this is imaging of the Meibomian glands. And again, for those of you who are like, what is that? It is the lipid content or the sebum that spills out of the mucocutaneous lid junction to coat the ocular substance or surface. And this particular procedure is designed to provide imaging of this area. It is also unilateral or bilateral, and it includes the interpretation and report. All right, we have a new code, 0508T, for pulse echo ultrasound bone density. This is a test that is used to identify individuals with osteoporosis. It can also monitor a patient's response to osteoporosis treatment. And here's the goal of this procedure. The goal is to reduce the patient's risk of fracture. So you'll notice that in this particular code option, you have the body part of tibia. Next up, we have code 0509T, which is electroretinography, ERG. This is a test that measures the electrical responses of various cell types in the retina, including photoreceptors, internal retinal cells, and ganglion cells. This particular code includes interpretation and report. Next up, we have a new add-on code for intraoperative visual axis identification using patient fixation. So again, this is an add-on code, and the intent of this code is actually to be used in conjunction with Category 1 codes 66982 and 66984. And those two codes are your extracapsular cataract extraction procedures. And so this new code was designed to be used in conjunction with those codes. All right, so remember we talked about wireless or leadless pacemaker. Well, in Category 3, we have a brand new category titled Wireless Cardiac Stimulation. And with the creation of this new subsection, we have 8 new codes. First 3 codes, 0515T, is for the insertion of this wireless cardiac stimulator device, and it is the insertion of the complete system. Notice that this code includes the device interrogation, programming, all of your imaging, supervision, interpretation when performed. A complete system is defined as the electrode and the generator, transmitter, battery. So 0516T is for the electrode only. 0517T is for the generator only. Of course, if we have codes for insertion, we have to have codes for removal. So 0518T is for removal of the generator. 0519T is for removal and replacement of the generator component. And then 0520T is for the pulse generator component and includes the placement of a new electrode. And of course, we must have codes for interrogation device evaluation, which is 0521T, and program device evaluation, which is 0522T. We have a new code, 0524T, that has been added to report endovenous catheter-directed chemical ablation, which includes balloon isolation of an incompetent extremity vein. You'll notice that this particular code has an approach of open or percutaneous. It includes all of the access, manipulation of the catheter, imaging, imaging guidance, and monitoring all in one code. All right. We have 9 new codes to report intracardiac ischemia monitoring services. This is actually a new device. There is one that I learned about that was FDA approved. And this particular device is intended to provide an early warning of ischemic events which are otherwise undetectable by patient symptoms. The goal: reduce the time between the ischemic event onset and medical care. So there are a total of 9 new codes. First code, 0525T, is for the complete system. 0526T, electrode only. 0527T is for implantable monitor only. One thing that I want to draw your attention to: all 3 of these codes include insertion or replacement. All right. The next 2 codes, of course, we must have the device programming evaluation. Notice it states in person. And then we also have the interrogation device evaluation. Notice these codes include the analysis, review, and report. And we now also have codes for removal of the monitoring system. So the first code, 0530T, is removal of the complete system. 0531T is the electrode, and 0532T is for the implantable monitor. All right, we have 4 new codes established to report the use of non-invasive movement recording device. This particular device is something that's used by those that focus on the field of movement disorders. such as patients that have conditions like Parkinson's disease, tremor, other neurological disorders that resemble Parkinson's disease. These codes are divided as follows. 05333T includes everything. The report setup, patient training, configuration of the monitor, upload of the data, analysis, initial report configuration, download review, as well as the interpretation and report. Then the next three codes separate or split out various aspects of the entire service. So 0534T is for our setup, training, configuration of the monitor. 0535T, data upload, analysis, report configuration. 0536T, download, review, interpretation, and report. All right, we have a new subsection titled Gene or Cellular and Gene Therapy. This new subsection brings with it new guidelines, and 4 new codes have been added to start this section out to reflect services around CAR-T therapy. Again, another thing that I was not familiar with. So this is a type of treatment in which the patient's T cells, which is a type of immune system cell, are actually manipulated or changed in a laboratory so that they will attack cancer cells. The T cells are taken from the patient's blood, and then the gene for a special receptor that binds to certain proteins on the patient's cells are added into the laboratory. The special receptor, FYI, is the CAR receptor. So what happens, large numbers of the CAR T cells are grown in the laboratory, given to the patient by infusion. And this particular type of therapy, again, is being studied in the treatment of some types of cancer. All right, so how are the codes divided? 0537T is for the harvesting. Notice it is divided per day. 0538T is for the preparation for transportation. 0539T is for receipt and preparation of the CAR-T cells for administration. And then 0540T is for the administration, and notice it is autologous, so it's from the patient's self. All right, we have a new technique to measure the magnetic fields produced by the electrical activity of the heart. This is known as magnetic cardiography, MCG. This test is performed by placing multi-channel sensors over the patient's chest, which then gives a map, if you will, of the magnetic field. And the end result, and you know, just by the nature of this test, there's some math involved. The map is constructed using these mathematical algorithms. The test is intended to assist in the rapid identification of cardiac ischemia that causes acute coronary syndrome. This test in particular was designed for situations when the patient's other tests are negative, but the provider still believes that they have some type of acute coronary syndrome. So we have two new codes. First code 0541T is a single study, which includes the signal acquisition, generation of those magnetic fields, the quantitative analysis, the scoring, and an automated report generation. And again, this is a single study. Now, there is a second code, and notice what this code does. This is for the work that's involved in interpreting and reporting the study. So this one is a little different because it doesn't include all of the services in one code. So your 0541T is the report generation, the single study, and then your second code is for the interpretation and report. Again, all of the information that I provided for you today was based on my own research using the 2018 CPT manual, as well as the CPT Changes Insider's View. Of note, Category 2 codes are still in the CPT manual. There were no changes to report this year, which is why I did not cover them. And given that this was a 90-minute presentation, I am sure you will agree that this was enough for 90 minutes. Again, because of the time that we had allotted for this presentation, we will not be taking any questions on today. If you do have questions, my email is displayed on the screen, and you can feel free to send me a question. Please, with the upcoming weekend, give me a week to respond, so around the time that you guys are getting those surveys. And I thank you so much for joining our ILHEMA CPT Changes presentation on today, and I'll turn it over to Ann.
Thank you so much, Dr. Campbell. I appreciate your time and expertise on this topic. I do want to thank everyone for joining us today. As another friendly reminder, in approximately 1 week from today's meeting, all registrants will receive an email from our webmaster, Knowledge Connect, with a link to the meeting handouts, a link to today's recording, and a link to the evaluation. After you complete the evaluation, you will then receive your CE certificate. And again, as another reminder, please address any questions that you may have to Dr. Campbell at the email address that she has there on the screen. Thank you again for taking time from your schedule to join us for this educational meeting, and we hope you join us in the future for other offerings that we may have. Have a good afternoon.